All right, here we go. Get your tomatoes out. Get ready to start throwing. There is confusion number 6, low vitamin D levels. There's a concept out here that we hear a lot of people talk about, and it's all over the United States. It's all endocrinologists worldwide, because our patients do come internationally as well. That the concept is that somebody has a low vitamin D level. So like the next 7 slides are going to be vitamin D levels. So don't throw your tomatoes yet. Just wait till I present some data. The concept is low vitamin D is the primary event. And because of low vitamin D, these people can get low calcium, and possibly through direct activation of parathyroid glands. The parathyroid glands become hyperplastic. This events are taking place. So the parathyroid glands become hyperplastic because of low vitamin D, which then eventually leads to a high increase in calcium. This is the concept of secondary hyperparathyroidism caused by low vitamin D. Patient comes in, they got a high calcium. The calcium is 10.9, 11.1. Their vitamin D is 16. Well, I think maybe the low vitamin D is the inciting event, which causes this, which causes this, which causes that. I'm going to give them some vitamin D to check that out. We'll give them vitamin D, right? Because if you give them vitamin D, we'll be able to, that should put these babies to sleep and the calcium will go back down, right? I'm here to tell you, there ain't no such thing. This concept does not exist. The concept that low vitamin D will cause a high calcium, I'll say it like the 4th time now, it doesn't exist. Let's look at vitamin D in thousands of patients. Now, as you probably all know, this is by far the world's largest database of this stuff. Nobody has this. In our database, of course, but we have a database of some 13,000 patients, but we've been showing you data for 10,000, okay, our most recent 10,000, because the data's cleaner. But of those 10,000, not all had a vitamin D drawn preoperatively, okay? Or some had vitamin D done preoperatively that were already taking vitamin D, so we had to throw them out. So 6,821 patients with a parathyroid, who we took out a parathyroid tumor. The mean is 19.4. 87% of patients with parathyroid disease, a parathyroid tumor, remember it's not hyperplasia, it's tumor, 87% are below 30, 52% below 20, 12% below 10. Let's look at it graphically. We presented this data 2 years ago at the annual ACE meeting in San Francisco 2 years ago. Almost all patients with primary parathyroidism have a low vitamin D. So here's 6,821 patients. And look what happens. Vitamin D on the y-axis. Here, look at the x-axis. Here is calcium levels. As calcium levels go up, vitamin D levels go down. All right? Again, mean is somewhere here around 19.4. Let's look at it even further. Vitamin D 125 in those same patients. As calcium goes up, vitamin D 125 goes up. So there's a higher conversion of 25 to 125 in these patients with parathyroid disease, okay? With hyperparathyroidism, with parathyroid tumor. We're not talking about secondary hyperplasia, okay? Tumors, all right? Post-op patients, these people all operate on, all have a tumor, okay? Not hyperplasia. Now, what we don't show here is we have another graph showing that previous thing where as the calcium goes higher, the vitamin D25 goes down and 125 goes up. We have another graph that I don't have here, but it shows as the x-axis is changed to years of calcium greater than 10.2, the same thing happens. So the longer they've had it, so it's not just the degree of elevation of calcium that causes the decrease in vitamin D25 and increase 125. It's the duration that these patients have had calcium greater than 10.2. So the higher the calcium goes, the lower their 25 goes, higher the 125 goes, and the longer the duration, the longer they've had calcium levels that are high, out of the 9s. Remember, adults live in the 9s. If they're in the 10s, they're going to have a low calcium. These are the same patients. At 5 weeks post-op, what happens to these same patients? We don't give them vitamin D. We operate on them, take out their tumor, and then 5 weeks post-op, we measure their vitamin D25, okay? Look what happens. They're self-normalizing, okay? So these patients who have low vitamin D preoperatively take out their tumor. So the only thing that's happened to these people, we take out their parathyroid tumor. We do give them calcium, okay? You guys all know we have a calcium protocol. We give the patient Citracal, you guys all know that. But we're not giving them vitamin D supplementation. That's what happens. They correct themselves. So clearly, a low vitamin D is has a protective effect. Something's happening. These people are protecting themselves. There's more of a conversion from 25 to 125. I don't know more about it than that. I can't tell you exactly how or why that's happening. I understand with the conversions in the kidney, and I understand that. But a low 25 calcium, low calcium appears to be a protective effect. So let's look at this. Since we have data, because our patients come from all over the planet, right? Our capture area is the world. Let's look at, in this particular data, 6,921 patients. The average vitamin D level is 19.3. We've changed from 19.4 to 19.3 because in this particular slide there's more patients, from 6,800 to 6,900. Let's look at the degrees latitude north for those of you. This is a globe and these are these things. We live here. We live here in Central Florida. We live between degrees latitude north between 25 and 30, okay? So we look at people who live further south than us towards the equator. Look at that. Their vitamin D levels are low. Look at the people who live up here in Canada, okay? 45, 50 degrees, that's up here, okay? That's up here in Canada. Look, we have a few of those patients, but statistically there's no difference, okay? So it doesn't matter where you live. So if you get these patients coming to you guys all live in Florida, you're coming in patients, gee, my patient got low vitamin D, their calcium's a little high. How can you have low vitamin D and live in Florida with their couch potatoes? Well, they're couch potatoes because their calcium's high and they feel like crap and they're fatigued and they don't want to do anything. That's why they're couch potatoes. And they got atrial fibrillation and they're obese and they don't want to do stuff. You know, you guys, plenty of those in your clinic, I know you do. But they've got low vitamin D when they live in Florida because they got a parathyroid tumor. Because it doesn't matter where they live, the levels are exactly the same. It's not like people in Canada have a really low levels. They don't. They all have the same levels. So, careful giving vitamin D to hypercalcemic patients. This concept, well, I think maybe it's secondary hyperparathyroidism because the low calcium caused low vitamin D caused the parathyroid glands to become hyperplastic, which caused they became autonomous. So we'll give them some vitamin D to check that out. We've got over 100 cases of sudden illness causing the patient to stop the vitamin D. We got 40 cases of a hypercalcemic crisis induced by an endocrinologist because they gave vitamin D to a patient with hypercalcemia. 11 required hospitalization, and we have 3 cases of documented stroke with people who've been given vitamin D by an endocrinologist when they had hypercalcemia as the endocrinologist trying to figure out whether it's secondary. Careful with that, folks. Is you're going to cause stroke if somebody's got a calcium of 10.4 or 5? No. But we've seen people with calcium levels of 12.4, 12.8, and endocrinologists give vitamin D to see if they can suppress it. Careful, 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 careful. You guys are going to do that. You're smarter than that. I've shown you statistical evidence that you're smarter than that. Bottom line, low vitamin D. Low vitamin D25 is expected in patients with primary hyperparathyroidism. Average value is 19. Low vitamin D will never cause a high calcium level. There's no such thing as secondary hyperparathyroidism due to low vitamin D that leads to a high calcium level. No such thing. A patient with a high calcium level and low vitamin D should be presumed to have a parathyroid tumor, not hyperplasia, a tumor. Well, low vitamin D should help you make the diagnosis of primary hyperparathyroidism, not want to rule out secondary.